Hello, my name is Dr. Palia, and I'll be presenting my group's QueST 2024 project. We worked on a project called Enhancing Glycemic Control in Non-Critically Ill Patients with Type 2 Diabetes mellitus on the medical floors. Involved in this project was Dr. Hannah Nadeem, Dr. Karina Torres, myself, Dr. Arman Assani, and our wonderful faculty advisor and endocrinologist, Dr. Sarah Makadsi. So the rates of type 2 diabetes mellitus have dramatically increased over the past decade. A significant number of diabetic patients are being admitted to hospitals with a prevalence of 11.6% in the United States. Noncompliance or lack of a standard inpatient hyperglycemic management protocol causes improper glycemic control. As a result, a glucose of 180 while inpatient does have a direct effect in patient outcome and length of stay. It has been shown in a consensus published by the American Diabetes Association that hyperglycemia in hospitalized diabetic patients is associated with an increased risk of complications such as diabetic ketoacidosis, peripheral neuropathy, confusion, as well as mortality and a higher rate of admissions to the ICU and higher need to transition to rehab facilities after discharge. Therefore, it is important to correctly identify type 2 diabetic patients and their diagnoses, to document their home medication regimen, and to initiate inpatient glycemic control protocols. The aim of our project was to collect data on patients identified as having the type 2 diabetes mellitus diagnosis, calculating the percentage of these patients started on inpatient glycemic control protocol, and then determining a strategy that would ensure a more significant proportion are appropriately started on this protocol. Per the 2023 ADA guidelines, it is recommended to initiate a regimen consisting of long-acting insulin, prandial, plus correctional insulin for non-critically ill patients who are having adequate oral intake in the hospital, or basal plus correctional insulin for patients with poor oral intake if their glucose is indeed above 180. Goal was to maintain a glucose between 140 to 180, and then this initiative would focus on enhancing diabetes care and reducing the incidence of hyperglycemic events during hospitalization. Ideally, this intervention will improve patient outcomes in the hospital and extend the benefit following discharge. To carry out our study, we engaged a random selection of 100 patients admitted to DMC's Huron Valley Sinai Hospital within a 3-month interval who were diagnosed with type 2 diabetes per ICD-10 code. These patients were admitted for a reason other than type 2 diabetes, but were ascribed the diagnosis through a detailed and thorough history taking. We applied a retrospective cohort analysis to obtain our data, and our primary outcome measure was the number and percentage of this cohort who were placed on inpatient glycemic control protocol described in the previous slide. With the 100 randomized patients admitted between our 3-month designated interval with the diagnosis of type 2 diabetes per their ICD-10 code as specified in our methods section, we found that 41% of these patients were placed on an inpatient glycemic control protocol, while over half were not placed on a glycemic control protocol, as this graph on the right portrays. Now, these results were below our expectations and highlights a substantial area for improvement. Strategies aimed at enhancing the implementation of a glycemic control protocol during hospital stays could involve various approaches. One potential strategy is incorporating EMR triggers to prompt consideration for patients identified as having type 2 diabetes. This could be integrated into the hospital's admission orders, similar to what we do for VTE prophylaxis in high-risk patients. Additionally, establishing standardized practitioner protocols to screen for type 2 diabetes and offer glycemic control protocols to identified patients may also be effective. And then increasing the activation of these protocols during hospitalization could potentially reduce complications, shorten hospital stays, and facilitate proper diabetic education for patients. However, it is important to acknowledge limitations in the study. Firstly, it did not capture data on patients who declined to participate in the glycemic control protocol, potentially creating compliance gaps. Secondly, qualitative data to assess objective patient benefits and outcome measures like length of stay were absent, and exploring such outcomes would necessitate a control group, which was not a part of our study. Nevertheless, this study sheds light on a likely systemic issue with significant implications. The data suggests room for improvement in the public health response to achieving tighter glycemic control. Future stages of our study should broaden the range of our outcome measures as previously outlined and incorporate methods to evaluate the effects of these interventions. Achieving success with these interventions on a smaller scale could have far reaching implications and address a major contributor to morbidity and mortality within our healthcare system, that is, type 2 diabetes. Thank you for listening to our presentation on enhancing glycemic control in non-critically ill patients with type 2 diabetes on the medical floors. We hope to encourage implementation of glycemic control protocol in facilities.